And I said, I don't know what that means. And he says, well, surely to God you're going to accept. But I had to think about that. What does that mean? And anyway, so after that, then Western decided that they would give me an honorary doctorate. So I have a degree in sacred indigenous knowledge, equivalent to a PhD, and then I have an honorary doctorate. So I guess it's okay, I'm settled with calling me doctor, but please don't feel like you have to call me Dr. Carol Hopkins. I think that's an important story in this context, is that racism takes many, many forms. And our knowledge and our language and our practices that have ensured our survival as Indigenous people have been colonized, and we have endured racism. In fact, I can tell you many stories about how the government said, well, I don't understand that, so I can't fund it. That all sounds good, but there's no evidence base to it, so we can't fund it. And so these ways of thinking, this racist way of thinking, it informs policy and it affects us as a people. But thank goodness we're in a time where we can have these conversations. And it is because of the suffering of people, and making this more known and more public, that spaces have been opened up where we can lead conversations and we can decide ourselves what those experiences mean. So this was the space for this conversation. The whole country has been having conversations about anti-Indigenous racism in the space of health. And so there was Brenda and I going, don't forget about mental health, don't forget about mental wellness, don't forget about addictions. That's part of the healthcare system. And again, it's the siloing. That Western way of thinking is just this, and just this. And there's no relationship across. Well, we know there is. So it's always advocating for that space. So, let me figure out how to change these slides. I also want to just take a moment to recognize the nations of people who have always lived here on this land. All of those ancestors, are looking after us in the blowing snow. Those of you who suffered all night in your car, in the ditch maybe, I feel for you. And your children. Those of you who had your children in the car. And even in those moments, it's hard to appreciate, but as I'm standing here before you, I know our ancestors are always looking after us. And so you survived, and we survived. So this activity was an effort between Thunderbird Partnership Foundation and First Peoples Wellness Circle, who really took the lead in this initiative. And so both of us have a mandate to implement the mental wellness continuum framework. That's what our work is. We work with different populations. But so this first couple of slides are really introducing First Peoples Wellness Circle. So do you want to speak to this, Brenda? Yeah.
Don't want to take a ton of time because we really want to spend some time talking about the work we did around racism. And as Carol said, we didn't want people to forget about the discussions around anti-Indigenous racism, because when they were having the discussions, we heard from doctors and nurses, midwives, folks like that. And Carol and I were saying, well, that happens in mental health, and addictions, that happens in mental wellness. And we also said that mental wellness, many of our people end up at hospitals because of addictions and mental health issues. And so this is part of why we're doing it. But very quickly, if you don't know who we are, as this slide shows, some of our work is very centered around supporting the workforce, supporting all of you in some capacity through different types of capacity building initiatives, networking and training, by providing tools and resources, toolkits, things. You might have been at our booth and saw some of those things that we did. And our intention really, we get confused a lot. Not only do I get called Carol, and she gets called Brenda. Some people think I work for Thunderbird, and, so we get confused, but what the reason is we both have a very strong belief in using our evidence through both research, evaluation, and all of our conversations at community level to ensure that we're putting forth the knowledge and evidence of our people around our programs and service, to put that as the center and the front, which is exactly what the framework pushes and talks about. And so in the intention of that is really to create some systems change so that not only is it included and promoted, but that it leads the conversations that we have and it leads the work that we do. And we do that through many different ways. This is our, most people talk about vision, mission, and all of those things. We've actually put it into hope, belonging, meaning, and purpose, which is part of the framework. And so our hope is really a vision for a better future. And our intent is really that we want to work to achieve the hope for the future of our people. I'm not going to read it, but it is there if you'd like to look at it, and the slides I'm sure will be available. I'll pass it to you, Carol.
So many of you have heard of the National Native Alcohol and Drug Abuse Program and the National Youth Solvent Abuse or Substance Use Program. So those two national programs are what established the National Native Addictions Partnership Foundation. So all of these acronyms were used like words, NAF, NADAP, NISAP, and people started wondering like, which one are you? And what does that mean? Well, they're actually not words, they're just letters that we pronounce like words. And so most of our focus was on addictions. That was in our name, National Native Addictions Partnership Foundation. But then we were asked to participate in the development of the Honoring Our Strengths, a renewed framework to address substance use amongst First Nations. And so we co-chaired a national committee along with the government and the Assembly of First Nations. And when we finished that work, we were asked, as well as First Peoples of Brenda, really, to participate in the development of the First Nations Mental Wellness Continuum Framework. So that expanded our scope beyond just the narrow focus on addictions. There's lots more that communities can be doing, given the right resources, even our thinking as a resource, how we think about what we do to address substance use. And so we shifted in 2015 to Thunderbird Partnership Foundation, wanting to identify ourselves in a way that would be visible to First Nations people across Canada. And we don't have just one language, and we have many symbols in our culture that are different. But the eagle lives everywhere across this land. And so that's the Thunderbird is that spirit eagle. And that's what the board of directors decided that they would adopt as our name. So like First Peoples, we promote mental wellness in community as well as in treatment centers are one of our core stakeholders. And so we going to talk about anti-Indigenous racism. So, like I said, the background was really that national conversation that had begun around the exposure of racism in the healthcare system. And so lots of conversations about that. We were invited to listen in, but then also to make comments about what people were talking about. So there's many systems in place within the healthcare system, and there isn't even really a system across Canada. But there's legislation that guides what healthcare does, and there is legislation about how that's service delivery standards that should be used to inform how healthcare is practiced and what are the standards of practice, those kinds of things. And in those standards, it talks all about quality. But quality did not protect First Nations people, has not protected First Nations people in healthcare.
and our needs have not always been met. And what we understand about health has not had space within healthcare environments. And so that's the background for this conversation. And so then in 2023, we were approached by Indigenous Services Canada to do something about what we have been saying related to mental wellness and addictions or substance use within healthcare as well. And so we wanted to understand, not just assume that we knew, we wanted to understand what First Nations, Inuit and Métis people's experiences were. We wanted to identify what are the potential ways out of that, because there isn't one solution and there isn't one way. There were many things that were said. There were many paths and many policies and practices that could be identified to help us move from this. And then what are the key drivers, or what are the key things that are going to create change or facilitate, motivate change to happen around anti-Indigenous racism. And so we had focus groups, invited people to different roundtables at conferences and virtual environments to have this conversation about the experience of mental wellness, addictions, mental health, and racism around that in the healthcare environment. And so we had lots of 5 conversation roundtable discussions, and there were 96 participants from across the country. This map shows you where, and some of the limitations were that we didn't have people from the territories or PEI, and there was a lack of Inuit people participating, although they have continued to express interest with First Peoples Water Circle and having the same conversation. But the people, 96 people who did participate and lend their voice to this conversation were the workforce. So the workforce is First Nations, we're First Nations ourselves, but we live in First Nations communities, our family lives in First Nations communities, Off-Reserve. Everywhere we are, you carry a story because you're supporting people as they access healthcare, mostly outside of our communities. And we have an understanding of those experiences. So the 79% of the participants were First Nations, and they came from working in community, health organizations, universities, political advocacy organizations like tribal councils. And so we used surveys, and there were, follow-up surveys with people after they participated in the roundtables. And then there was an analysis that there was some help in analyzing the data, and then there was a working group as well that helped us to understand what the story was telling us from those roundtables and from the surveys. So these are some quotes. In September of 23, after this discussion, or in this discussion, people said, one participant said, they do a lot of performative things to make it seem like they're doing work. But on the ground, in practice, in reality, racism just continues. So they might have a policy, they might have a poster on the wall, but when you're face to face with the healthcare provider, you still continue to experience the racism. The stereotypes are there, the assumptions that are made, and the questions and the interactions with people in healthcare, they're all built into the system. They're in the education. The education of the healthcare workforce is absent of an understanding of our needs and our reality, our way of thinking, our worldview, our values. And they haven't been addressed. And so those, I say educational institutions, and I'm always corrected, it's a community. Somebody from the university will always tell me, this is a community, Carol. And I can't get my mind off of referring to them as an institution, because they still perpetuate a knowledge system that is largely dominated by a Western worldview. And we're always reminding, don't forget, do not teach your students that we have no evidence base, that we don't know, or we don't have an understanding. And so it's a box checking exercise. We got the policy done, we're good. We're not good. So the, when racism exists, there's an absence of the right kinds of services for First Nations people. And so you can't expect to receive what you actually need. And it's not always safe, it's not always the right kind of service, it's not adequate service. Despite legislation that exists across the provinces that service providers will deliver services against a set of standards of excellence. Those standards of excellence have not always proven to be excellent healthcare for Indigenous people. And so the quote said, for 2 years I've been trying to get her into rehab, trying to find all the supports for her. And then when I get her into the emergency department, she's ready to go, but we're sitting around for hours and we're waiting. And we know it's because she has an addiction. And so that perception, if you have an addiction, well, you've done that to yourself, so you can just wait. There's no empathy and there's no compassion if you are suffering in some way because of the addiction. And so by the time I sit there with her for 3 hours, she gets agitated and she decides, that she doesn't want to be there anymore. And so that pressure that a mother might feel when she's desperately trying to save her son or her daughter from the clutches of the dependency on whatever drugs or substance they might be using, and they're waiting in this environment. And maybe everybody else has also waited 3 hours or more. But her perception is, because I'm Indigenous, that I'm not going to get the services I need because there's no compassion in healthcare for addictions. And then there's always this confusion about jurisdiction. So, in Ontario, I'm sure you remember the news that reported how the ambulance wouldn't go on to the reserve. So you call an ambulance and the ambulance comes, but they stop at the edge of the reserve. And if you actually want to go to the hospital, you have to figure out how you're going to get from your house in the reserve to the ambulance. That's racism. But what do they say? That's a jurisdictional issue. My brother, he lived with schizophrenia. And for many years, we were fighting the healthcare system to get him consistent care. And finally, we found out about this service in Ontario. It's called an ACT team, acute care team, that comes out and works in the community with individuals, but not if you're First Nations. And we live in a very populated part of Ontario, so we're not even talking about rural communities. They drove right by the house, but because the house was on this side of the road, that's reserve land, they could go down that road and serve all of the people that lived on the other side of the road, because that's not reserve land. And so a lot of fighting to get them to pull in the driveway and provide care for him. And when he finally got that care, he did really, really well. So jurisdiction that says provinces are not responsible for our mental health and addictions needs on reserve. Well, the Canada Health Act says universal access to health care. It does not say this legislation applies to everyone in Canada except for all you Indians. Don't expect anything from us. It doesn't say that. It doesn't say universal health care for everyone except for all you Indians. And I'm using that word facetiously because that's still, the Indian Act is still legal. It doesn't say that. And people will say, oh, that's a jurisdictional issue. That was a polite term that we used, and our leadership and politicians also use that word, jurisdictional issue. It's not a jurisdictional issue. When they leave us out, don't make a mistake. Don't be mistaken. It's called racism. If you do not get healthcare services simply because you're First Nations or because of where you live, that's a racist policy. It's called racism. It's not a jurisdictional issue. There is no confusion. It's called racism. And that's what participants said. Go back to the reserve. That's what they said, we're told. Go back to the reserve. An elder was talking about going into a public health office to collect information pamphlets about health promotion. She was going to take them to the community where she was going to visit, First Nations community. And as she's collecting all these pamphlets, you know, the staff in the public health, meaning public, everyone, came over and said, what are you doing? Where are you taking those? And she says, I'm taking them to the reserve. Oh no, put those down. Not for you. Not for you. That's racism. If you want that information, you have to go back to the reserve. That's racism. So that's what we are hearing. And then we continue to have policies, funding policies that are colonial and that perpetuate colonial thinking. You know, so we've done a lot of work to understand indicators and measurement and outcomes. But for many, many years, especially in the space of mental wellness and addictions, the belief was that we have no evidence base, so we're not collecting any data, we have nothing to tell us about how well our services do or the outcomes that are achieved through our culture-based practices. And I remember being invited to a Mental Health Commission of Canada conference, and every speaker that was talking about Indigenous mental health was not Native. They were white adult men. And I had hopes when one was talking about the importance of land-based services. And I thought, oh, finally, somebody gets it. But he concluded his speech with, but there's no evidence that that actually works, so we don't fund it. And so colonial policies, are we measuring the right things according to the government? In the last, before we have the current government in Ontario, Minister Hoskins said, you know, First Nations people, they tell me they want funding for land-based services, but I don't understand what that means. And I ask people, well, what does that mean to you? And they have a hard time explaining what that means. He goes, and they've actually said to me, well, I could explain it to you, but, you know, it would take a long time, and we probably still wouldn't understand it. And I laughed, and he laughed, and he said, you know, and that's probably true, but I need something so that I can create the policy to ensure that there's funding. So somebody has to explain this to me. And so Thunderbird developed a land-based service delivery model. And that's the work of Thunderbird as well as First Peoples Wellness Circle, is to take these concepts and align them with language that is dominating the way we support mental health and substance use services, so that others can understand it, so that the government can put it into policy in a way that it's understood. So we have to find that space where we do relate. And racism causes avoidance. Like, people don't want to deal with this. They don't know what to do about it. They don't want to hurt somebody's feelings. Meanwhile, you know, people are dying because of racism. And so it's a complex issue. It's a complex issue. It's hard to address. But we shouldn't let complexity and difficulty be the barrier for ensuring that First Nations people can experience and exercise their right to live life, just because it's complex, just because it's difficult. And so we have to hold people accountable, you know, and they say in a very polite way, well, you know, that's going to be really hard to do. Of course it is. Of course it is. It's going to be hard, but we still have to do it. So, you know, the results of all of that, it leads to poor health care. And then there were recommendations, and that's what Brenda is going to talk about.
So, you know, that was some really important conversations we heard from people who came and shared with us their personal experiences, the experiences of their family and of their community, and of the work that they did. And we asked them, so what do we do? How do we make change? What will help to create equity in our system? And they provided us with a lot of really great recommendations. The first one was around, there was two main areas. The first one was in the area of systems transformation, and the second was in looking at resistance and reclamation. So the first one was talking about the creation of education and training specific to anti-Indigenous racism. We have been hearing for a long time about cultural safety and creating cultural safety training, cultural awareness, cultural sensitivity training, and we know that that is important, but it continues the conversation from an us-they, us versus them. Anti-Indigenous racism places at the center of the conversation the need to address systems of power, and that those who are providing care are using systems of power to harm other people, as opposed to an us-they. You need to treat us better. This is more about how power is harmful, and that they said to us, we need to be able to discuss things like white privilege, bias. We need them to understand how their ways of thinking, their ways of doing continue to harm us. And we need to have this training come from a strengths-based approach, not about, oh, poor First Nations, Métis, and Inuit people. We need to make it better so they can get into healthcare, but rather about the fact that us as Indigenous people, as First Nations, Inuit, and Métis, we come, as Stan said, with gifts. We come with strength, we come with resilience, and we wish to be treated in systems by recognizing what we come with and not what we don't have. And that's how the systems currently treat us, with what we don't have and how they're going to make things different for us. They talked about how they want us to be thinking in racism and education training about relationships and creating reciprocal relationships, that we are equal and that we have much to bring to the conversation. We have much we know about our own healthcare, and those are things that need to be shared within education and training on racism. And they said it really has to come at the local capacity. And so in the last year, First Peoples did some work in New Brunswick where we brought workforce together and we created a curriculum about the colonial harms that exist in New Brunswick, not just from a long time ago, but from current, with their fishing boats and all of the different things that have happened to them. And we use that to build capacity around the challenges of colonial harms that they still face, but they also built into that curriculum all of their strengths, all of their resilience. Here's what we're doing. Here's what's making a difference. They talked about land-based camps. They talked about putting their knowledge first, about using cultural practices. So those were the kinds of things that when we went back and talked to the folks in New Brunswick, both the what we call the mentors, the First Nations people, they came back saying, I felt so empowered to be able to share what we are doing. Not only what has harmed us, but what we are doing. And on the flip side, those non-Indigenous learners from psychology and social work said, I had absolutely no idea that these colonial things were still happening. I didn't realize what it was doing to people in the communities. But I really had no idea the amount of amazing work happening in communities. So beginning to show that we really do hold the evidence and the knowledge, right? That we've always known, but giving it back to them and helping them to see things around how our elders and how our practitioners really support well-being. And so really helping through an education system, we've heard that it's important that this be mandatory training, whether that be at a workforce, in those educational institutions, or whether it be through professional associations. But most importantly is if you're going to do this type of training, that there needs to be an accountability measure, and that accountability measure can't be built into those associations and education systems that just say, oh yeah, we did that and it's all working. That us as First Nations, Inuit and Métis people, we need to be able to assess it and say it is working or it's not working and what needs to change. We also heard it was important that there be self-determination in this transformation. So if we're going to transform the system and begin to share the power of how we deliver services, that it has to really come from a place of being meaningful, and it needs to be sustained. In fact, this work we've been doing on racism, we're having conversations, New Brunswick, others were really excited about it. I went to the government and I said, we'd like some more money to continue it. Oh, we're not funding that this year. So all of a sudden racism is no longer in vogue, and so we're not gonna fund that. And I'm fairly certain after 1 to 2 years of talking about racism, we're still experiencing racism. It hasn't gone away because they've given a little bit of money. But you see from this quote here that this participant says, the challenge around racism is there's no resources for any of our organizations to be represented. Who's going to do the advocacy but us? We need the resources as First Nations, Inuit, and Métis people to be at those tables to make the change. We also heard about accountability and justice, which was in that very first slide. So as I said earlier, having Indigenous-led processes where we are doing the oversight, we have decision-making, there is that engagement and relationship building, and that we are building in our own practices and models of addressing racism because they cause harm. And in order to have reciprocal, meaningful relationships, we need to address the harms that have happened. And if we think about the Canadian Medical Association, they have stepped forward and given an apology because they've done some of their own work in going back into their files from 100 years and saying, we have done these things. And now we are prepared to talk about what it is we have to do. It is those kinds of areas that not only do they have to step forward, but we also need to engage within the Indigenous group to talk about what are the meaningful ways that we need to address and be held accountable. And so whether it was across the country or in our conversations in New Brunswick, it's been said that we have to be involved in the regulation of those accountability measures, in the creation of them, and that we have to continue to ensure that we're measuring them so that we're measuring the system to see if they are in fact addressing racism. Looking at indigenizing education and training. So as Carol was talking about, those education system value and hold Western knowledge as the way of looking and seeing and doing, but there was a lot of work and conversation had by the participants about the epistemic racism and the need to dismantle that Western-centric curriculum and training that we have, and rather to look and establish curriculum and training so that it is culturally relevant and safe, and that it also holds as credible the knowledge that we have as First Nations, Inuit, and Métis people in a way that centers that work for our people. And giving the importance was that we need to see more of our people in these systems so that our young people can feel safe in the systems and move forward in the systems. And I say to you that in talking to graduate students, we just had a conversation with Indigenous scholars and graduate students and heard 2 stories. One from a scholar who talked about when she started to challenge the racism within the nursing system. She's now a trained psychologist. She said, as soon as I started talking about it, the people in my department said, oh, we're not racist. Like, no, we're not having that conversation. And they began to shut her down, and they began to not give her classes, not give her funding. She said, I had to leave the nursing curriculum and move over to another one where I felt safer, where I felt that it was okay to talk about these things around racism. And she wrote different, I guess I'd say, tools around how to assess and look at racism and address racism within nursing. And then heard from a student who said, I listened to a psychologist who had worked in Northern Ontario, and she had pictures up about our young kids playing out on the reserve. The houses are not in great condition. You know, the kids are looking dirty, maybe playing without shoes. And she said the comments that this teacher was making made me so angry. And I thought, does she even have permission from that community, from those people, to put those pictures up there? Does she have permission to say the things she's saying? And she was making derogatory remarks. And so she said, I was so angry. I left that, that class, and I was upset and I was crying. And then we had an opportunity to do an assignment. And I went and I made an assignment where I challenged all of her assumptions about our people, and I raised up our knowledge, our evidence, and the work that is happening in our community. And I was shunned. I was shunned by a teacher who said I didn't know what I was talking about. I started to get shunned within my department, and I felt very alone. And it's the last time I challenged people in my department, because I just need to get through so I can go back and figure out how to work with my people. And that's happening today. And so it's these types of things that we need to have our scholars there, but we need to have them protected and safe to be able to make the changes in the system. We also heard it's important around recruitment and retention within those systems of healthcare where Indigenous people need to be, again, to be able to see ourselves in those systems and to feel safe. But we know that sometimes those systems hire one person to do everything. They're responsible to explain all the things about First Nations, Inuit, and Métis people. They're responsible to do the training, they're responsible to help the clients, they're responsible for everything. And so we heard that it's important to really invest in that and have cluster hires, so there's not one person who's responsible for everything, who could be burnt out, who could be harmed, but having cluster hires and ensuring that there is a group of folks who can support each other, and ensuring that there's things like pay equity and ensuring that their workloads are manageable and sustainable, and that there are partnerships between those organizations and our First Nations and Métis organizations to support each other and to support those folks in the mainstream system, and to develop programs around mentoring and leadership for those who work in these systems. We heard it was important to increase access to services, so being able to ensure that they meet our needs and our priorities and the realities, and that they need to be co-designed with us, that they can't be done without us in the room, without us at the table having the conversations. And of course, the ongoing need for funding, that it needs to be long-term and stable. And that there needs to be service standards. We need to have standards that are based on our ways of knowledge and evidence and knowing, and some of those standards have to include things you see here, like cultural safety, but also around understanding and the use of our holistic approaches to well-being and our healing practices, and that those programs need to be developed from our knowledge and evidence, and they need to be determined by us in terms of what they look like and how they are delivered, and how they are even evaluated, and how they are continue to evolve to meet the needs, because we know that our culture evolves and it changes as we evolve as a people, and there are some things that are foundational, but there are things that change, and we know that. If we look at when I was a young person, people who were using didn't go into cultural ceremonies and practices, and now we bring them into there because we know they need them now, not later when they've abstained or they're clean, and that we need to have and find culturally relevant and appropriate assessment and treatment models, and we need to be able to do the same with data collection and evaluation. We also heard that it was important to assess the strengths and center our knowledge and our practices in those programs and services. And really, I commend the organizers here for the amount of opportunity there's been to listen to lived experience, and how that needs to be included in our services, is there needs to be that lens of the lived realities, including things like our rights and around our legal status, but include the things like the social determinants of health and culture as a big and important component of that, and looking at how it can build resiliency and how it could foster our own knowledge and support families and communities in their well-being. But of course, in everything at the end of it is the importance of funding and the commitment from funders, but also institutions and systems like education systems and others to be able to fund that. That the care that we get needs to be holistic and culturally relevant. We've been talking about that. And that it needs to meet our needs at all of those levels, including at the spirit level, which is what was shared with us this morning in the opening. And that there needs to be space for research that is Indigenous led by our scholars, by our research people, to begin to identify policy and program changes and how they must come from our knowledge and evidence, and to be able to monitor those ways of attending to racism. And there needs to be more support around Indigenous-based evaluation measures and how to use them, so that we are collecting data that makes sense for our communities, and to be able to adapt and adopt those best practices that have been identified through places like the First Nations Information Governance Center. We know FNIGC has been collecting a lot of data, and how can we use that data to inform our work. In the area of resistance and reclamation, this quote here talks about a dream world that is not focused on eradicating racism within healthcare or education, but rather to step outside of that and allow us to create a space and funding and opportunities where our children, our young people, our elders come together and build that up themselves. So instead of taking the existing system and tearing it apart, let's build something that works for us. And in the area of resistance and reclamation, we heard the importance of attending to the Indigenous social determinants of health, that our well-being is made up of many pieces. It's made up of our culture, the history of our people, the socioeconomic factors and the environmental factors, and that all of these must be a part of the work we do to attend to racism by addressing all parts of our well-being. We also heard the importance of relationality and generating what they called collective strength. So really, relationality means responding to anti-Indigenous racism at all levels of the system, no matter what. And it implies that we have some responsibility to attending to that, and that there is a responsibility not just by us as Indigenous people to do that, but by the non-Indigenous system to do that as well, and to do that together. And that we need to have collective voice for that advocacy around equity in these systems. So things like having equity in our workforce and their pay. We know that we work really, really hard. We often do a lot of different roles. We support lots of different people, but we don't get paid the same thing as people working in the cities. In fact, many of our people, Carol says this all the time, like we train our people, we give them good skills, good knowledge, good evidence, and then government and non-urban and urban centers, they steal away our people because they have so much strength, so much skills, and they don't have to work as hard. It's not as complex. So they steal them away because they have more money. They offer them more money, and we've seen that in government. Why don't you come work for us? You know, and that's really hard to see our people leaving, and being able to keep them with us is important. And having distinctions-based standards of care, so what is needed for First Nations versus Inuit or Métis, and the creation of a mental wellness workforce association based off of our own competency standards, based on our knowledge and evidence. And if you wonder what that's about, Carol and I will talk about that at 10:30, so you can come and listen to us again if you're not tired of us by then. And then being able to support what we've been working on very hard, and that's our cultural resurgence, that revitalization of language and our practices. And I see he's coming, so I've got 5 minutes. And supporting these distinctions-based continuums. So each of them have one. Métis are not yet having those conversations, but there is an expressed need and interest by us for here in the room, First Nations. It's our framework, which it's our 10-year anniversary of the framework, folks. So you know that we've been leading the way in this conversation. And I applaud all of you for implementing that in your communities through your culture and bringing about hope, belonging, meaning, and purpose. And I heard that on the stage yesterday with our lived experience panel, is the hope they have and the meaning and purpose they have in their life to live a good life. That's because of our culture and the work that we're doing. So we heard that it's important to keep this conversation going, being able to talk about it at all levels of government with First Nations, Inuit, and Métis people so that we can understand the experiences of racism and that it needs to happen across multiple places, including scholars and students and youth, but also with multiple and intersecting identities, understanding it from those with disabilities or gender identity or even class. And so we, as Carol mentioned, we've been having a few of those conversations. We've had some opportunity to talk to scholars and students. And yesterday we had a great conversation with an Inuit provider and learned about some of the challenges in the north and how they are amplified or enhanced there. And so this was what we heard from one of our survey respondents. Our health disparities are a known outcome of systemic racism that we experience. We have the highest overdose and suicide rates. We have a population in this region with no hope. Racism is pervasive across systems, and a training course is unlikely to correct institutionally indoctrinated beliefs. Until we decolonize systems, we will be at the mercy of systems designed to assimilate us. And I think it's a very valuable quote because it talks about the need to create something that meets our needs and that we have that capacity and ability. And that's what you're all doing in your communities, is building a system that works, not necessarily taking what's there and just trying to recreate it. And so with that, I say miigwech.
Oh, we're good. I'm sorry, I thought you were saying Harold. Let's give it up, everybody. Come on, the doctor, Dr. Rasool. Such a gift. Such a gift. Dr. Rasool and Dr. Hopkins are moving right into their workshops. You're going to see Dr. Rasool after lunch as well presenting. You're going to see in your workshops, there's a lot of people that are taking over the workshops essentially for this morning, and that's wonderful, wonderful stuff. Everybody know where you're going? Are we good? Okay. It's 10:13. I'm feeling like extra happy today, so I'm going to give you an extra 2 minutes for your break. Does that sound good? Okay. All right, everybody, you're good to go. So take a break, and we'll see you in your workshops at 10:30. We'll be back here for a 30-minute lunch starting at 12.